What if the next breakthrough in healthcare isn't a new drug or AI model, but a whiteboard, a lunch hour, or just a few nurses with a few silly ideas? Dr. Chris Olson, Vice President of Design Impact at Mass General Brigham in Boston, joins the show to share how his team uses human-centered design to solve big problems. Greetings, everyone. This is Eric Glazer, and welcome to Bright Spots in Healthcare, produced by Bright Spots Ventures. We are dedicated to accelerating innovation through content, communities, and building meaningful connections. And our mission is quite simple. It's to spotlight what's working in healthcare and figuring out how all of you could help scale it. We bring together leaders from health plans, hospitals, and other innovative companies to share these proven strategies that drive measurable impact. And through our podcast, the one you're listening to today, our executive councils and private events, our go-to-market strategy work, we're surfacing and amplifying the bright spots in healthcare, proven innovations that others can learn from and replicate. And at our core, we exist to foster trusted relationships that fuel real progress, because we believe the best way to improve healthcare is to find what's working and clone it. Hopefully you are listening to this because you've subscribed, but if you've been passed along this episode, I highly encourage you to subscribe to this show and get access to all the great guests who come on each week and could provide you ammunition to transform your organization and positively impact healthcare in our country. So just go to wherever you listen to podcasts and type in Bright Spots in Healthcare and subscribe. All right. When we think about innovation, we often picture AI, robotics, new drugs, new therapeutics, but sometimes the biggest breakthroughs come from the smallest bright spots already hidden in plain sight. Years ago, in a Pittsburgh VA hospital, one janitor consistently had dramatically lower infection rates in the rooms he cleaned. Same supplies, same protocols, but better results. He used his own checklist system on how to clean that room. And once the leaders noticed the rates were so much lower, they studied what he was doing differently and had him train his peers and spread that practice from floor to floor. And then the VA decided to take that and move it from hospital to hospital. So it started as with one person on one floor, ended up changing infection control practices across a nationwide system, our largest nationwide system of hospitals. That's the power of positive deviance, finding what's quietly working and understanding why and amplifying it. So joining me today is Dr. Kristian Olson. He is an internist and pediatrician who also serves as the Vice President of Design Impact at Mass General Brigham. He leads the Springboard Studio and has spent his career applying human-centered design to solve complex challenges in both the U.S. and other global healthcare settings. We're going to talk about U.S. bright spots. We're going to talk about some global bright spots. So, Chris, welcome to Bright Spots in Healthcare. Let's dive in. We've been planning this for a while. Chris and I actually met in person to prepare for this, so it's going to be a good show, right? Let me throw out the first question. Why does healthcare need design thinking at all? And how does your framework help teams slow down to really understand problems before like that rush to solution?
Well, Eric, thanks so much for diving into this topic. I think that healthcare is under incredible strain right now. We're facing a lot of headwinds with decreased reimbursement rates, with a aging population, and with a healthcare workforce that's on the brink of burnout. And we know that it might have peaked during the pandemic, but burnout has dropped and people are lauding this drop, but it's still 45% amongst physicians. And now that it's being measured in other groups like nurses, you're seeing it's still, in many places, still 60%. And so with these headwinds, you're just realizing that necessity is the mother of innovation. There's never been a time where we need better ways of solving problems. And the way that is really developing solutions that are more compelling to the end user, more likely to be implemented, is design thinking, with a subset of that being human-centered design.
So tell me a little bit about how that framework, what is that framework? And in fact, let's like, what does design research look like in practice within a hospital? And like, how do you get past what people say and uncover what they actually do? Like, let's just take us into story time here.
Right. And so what we want people to understand is that design thinking is not making things look better. It's actually just a way of solving problems. And one thing that's really true, Herbert Simon said this, the 1978 Nobel Peace Prize winner, or not Peace Prize, the Nobel Prize winner in economics. He said, everyone designs who endeavors to change a current situation to a preferred one, and was really the one of the underpinnings or laying the groundwork for design thinking. So to dispel a myth, this isn't just another toolbox that people have to learn anew. We're all designing every day, but the idea is that you use a process with the end goal of implementation that utilizes creative problem-solving techniques, and then you really nurture a mindset where people have the humility to recognize that they don't have a complete understanding of a problem when they start, and then the empathy to really look at each issue from the other stakeholders' vantage points. And so the way that we practically implement it within healthcare, which is time constrained with high stakes, is really be respectful of frontline providers and staff of their time, but get their involvement in concise blocks of time during their regular work schedules.
So can you share a story that like truly like where understanding that root problem led you to a completely different solution than what others initially expected?
Right. So let me tell you about one where we're working with our population health management group, and we worked with Salem Hospital north of Boston around this issue of inpatient mobility. So just patients that get admitted to the hospital don't move for several reasons. And it's well documented that if patients admitted to the hospital move more, they get less rates of dementia, and that they recover quicker. But there's so many barriers. And when we went to this hospital that we're partnering with to figure out how to solve this problem, when we started looking at potential solutions, we really encourage people to be creative. And it's something that isn't encouraged in healthcare for a number of understandable reasons because of time constraints and high stakes.
Chris, before we get into that for a second, just to give everyone, I want to get everyone really into this story. Give me a time frame roughly that you're talking about, so we know like what kind of technical assets you may have influencing you, and also maybe how many beds, so folks listening can get an idea of the scope of and size of the organization you're working with.
Right. So in this hospital, there's say about 240 beds. We started inpatient beds, and we started small, just in 3 wards or 2 wards, 3 services, and it was about 70 beds. And so when we evaluated, we wanted to look at the mobility in these surgical and medicine patients, implement a solution, and test that over 3 months. So we did an evaluation really over 6 months.
Approximately what year was this?
So this was 2023, 2022 into 2023.
Okay, so fairly recently. Love
Yes.
this. Keep on going. Sorry to interrupt.
No, so we went in, and what we started with was, rather than coming in with a solution saying, hey, we think this would be a solution, and trying to get buy-in, which is something that happens often in healthcare. We went in and really identified stakeholders, like who all would be involved in this, and then asked those people that we identified who else should be at the table. So we brought into a room and a space on several occasions a group of physical therapists, frontline bedside nurses, patient care associates, case managers, and hospitalists, and sat down and really got them to think about, why are people not moving? And so one of the things we like to do in these sort of unmeetings, as we call them, is to stimulate creative confidence and really creating a psychologically safe space. So one thing we'll start with, as an example, is a question storm, where people might be more self-editing or quieter to speak if they're talking about coming up with a solution right away or trying to come up with answers. But when you come up with just questions like, why are people not moving? And then there were all these theories. People were really throwing out a bunch of potentials. And then
How do you set that up in a meeting where you're just saying you can only ask questions, and we're just going to dive into just peeling back the onion as much as we can? Okay. So, and how long does that typically take? Like, are you not putting that time restriction on it?
No, we really have to put time restrictions on, because it's one of our limits, right? You might buy people lunch, you might have them for an hour, and we might spend the first 15 minutes of saying, hey, grab lunch, sit down. We do say things like check your ego at the door, and we're gonna have this unmeeting. We're gonna move towards something we're gonna practically try to solve with.
So what's the size and scope? So we have your team and people at Salem, and so how many people? Like, what's the optimal number? Or maybe there's not one.
Often these meetings will range in size. That one was about 30 people, and we'll break into several tables. So there might be 7 to 8 people at a table, and then interacting and throwing out. And we'll either do smaller group question storming, for example. We might do an exercise really quickly, like within a few minutes, to stimulate curiosity. But we might do something like the stupidest ideas, so that people's egos are dropping, and that they're more likely to speak up and realize that even their stupidest idea will be collected, and then we start moving into.
Hold on, we're not leaving. You're going to come up with something called stupidest ideas. We're not leaving that quickly. Hang on. So tell me how that looks. For what does that, how do you frame that, and what are some of the things that people are willing to spit out? Maybe give some real examples. You don't have to mention names.
Yeah.
The other thing, I think, just give me the makeup of the group. So 30 people, 7 to 8 rounds, maybe 7 tables, so to speak. That's fine. No, that math's way off. More like 4 tables. I get it. Great.
Yeah.
So are we all doctors? Are we some administrators? Are we got some accountants, some tech people in there?
Yeah, I think the biggest mistake is to have only administrators or only physicians. You might get a lot of consensus, but a lot of self-backslapping saying, hey, great idea. That's what I would have had as well. So we really encourage the frontline staff workers. We had nurses in that room, physical therapists, and patient care associates, or PCAs, as well as hospitalists, and a few administrators and case managers.
Okay. And a stupid idea would be, or how would you frame this?
Yeah, let me give you an example of one that was really surprising to me. Sometimes you'll come up with even a theoretical scenario. Like, we'll say, hey, one that we did was, I want you to imagine creating the worst amusement park you could ever imagine, and describe why it is the worst and how you're going to make it even poorer. And we didn't really anticipate this, but people would laugh, and I think joy helps with creativity. People would start laughing and they're thinking about their own experience and then they combine all their bad experiences. And somebody described one and they said, you know what? I just described what we put our patients through when they try to come to an appointment. There's long wait times. Then you're racing there to make your appointment, but then you're forced to wait in a long lineup. You don't know what's going to happen. You might be filled with fear because of the ride. That's part of the reason you were there. That might not go along with healthcare, but it made everyone outline all these things in an entirely different mindset than what we were addressing during that session, and people were really speaking a lot by that point. We're anxious to give their ideas, and then we transition quickly into the problems that we're solving for that hour. So one thing that we did at working in Salem Hospital, just north of Boston, it's a 212-bed hospital. We worked with population health management who were coming in and really trying to increase mobility of inpatients. And so that's a big problem. Many people have addressed it over time. There's great evidence that people that move more when they're in the hospital get less delirium and they recover quicker. So why doesn't it happen more? One of the things we did in working with 3 wards and or 2 wards, but 70 beds and a few different services is go in and first identify who the stakeholders were. Who are the ones that are interacting with those patients, might get them moving. So we had physical therapists, advanced practice providers, we had hospitalists, nurses, and case managers. And we'd identify some and then ask people like, who else would you have in this room that really helps with mobility? And then we don't have much time. So we buy them sandwiches and get them lunch, and they'd get covered on the wards for an hour. And we go into a room, and one thing we tell them is that this is an unmeeting, and we start with it saying we're going to end up at a place where you've taken us with your ideas further towards a solution. And one thing we find in healthcare is that we haven't stimulated creative confidence, that people's ego barriers prevent them from speaking more. There's a number of understandable reasons why people haven't nurtured their creativity. And so one thing we do just as we start these meetings is try to get people talking. And so one way we do it is with a stupidest idea exercise, where we might come up with a theoretical solution. If you come up with a real solution, that works as well. But I'll give you one example that we used for using a stupidest idea is we said, well, imagine that you're creating the worst amusement park experience that you could envision. And people start laughing. They go, oh, I have some real examples. And then they combine all their worst examples together. And sometimes people give one and we go, that's bad in a good way, because that's what we asked you to do, but it's not bad enough. And then people get laughing and they even create another one. One thing with that example that came up that was so illuminating is somebody described their entire process of trying to find parking, having a long wait in a waiting room, never knowing when they're going to get on the ride. And then at the end of this whole experience where they go in and they're feeling sick after the visit, they said, you know what? This is exactly how we describe what we put patients through when they come to an appointment. And it really ended up being this great identification of pain points just from using this technique of a stupidest idea. And from there, we move into the work of the day.
So before we go into that, because I want to hear about the work of the day for sure, who frames out the stupidest idea exercise? Do we do 1 or 2 of those rounds with 2 different frameworks, with the amusement park being one of them, or just one? And why are we doing that specifically? Just as an icebreaker, or and did you just land on some residual value coming out of the hospital metaphor by accident? Like, who comes up with that? That seems to be a pretty creative scenario for the stupidest idea, is the amusement park. Did you guys come up with that because you thought there were connections to the hospital experience ahead of time, or just got there by accident?
What we always say is that there's the unknown of how the meeting will progress, who's in the room, how they're going to respond. That one ended up with something that was directly translatable to a hospital experience. At worst case scenario, it takes minutes. Like, we're talking 4 minutes of your hour, and you can imagine a lot of other scenarios where maybe there wouldn't be that connection, but the reason to do it is to get people in a different mindset. How many meetings do people go to where they're half falling asleep? Maybe they get lunch. They're just waiting till the meeting's over to go out and do the next thing, but to really engage them in a process. So the other thing that we'll do early on is, rather than starting with brainstorming, which makes people say, oh, I've got to come up with something intelligent, is starting with a question burst. And we'll do that practically around the problem that we're addressing, such as why aren't people moving when they're in the hospital? Why are things the way they are? And what are your biggest concerns about even getting involved in trying to solve inpatient mobility when other people have solved it for years? Like, what are your biggest concerns about even being engaged in this process? And writing them down as people say them, you get a lot of consensus in the room saying, oh yeah, that's a great point, or oh yes, and so we have very few rules in the room, but we do encourage yes and, not no buts. And it really leads to a place where you can get a better, deeper understanding of what the problem is. We've usually done a lot of background work to understand some of the evidence in case people are really asking for it, but then we're looking for practical solutions. So
just to get the we have these roughly 30 people. We're in rounds of 7 or 8 people. We start with the stupidest ideas for an icebreaker, and you guys come up with the scenario, the amusement park example for one. I'm sure you have others that you have in your back pocket. And then we do question storming, or a question burst, and that's just really just questioning everything. Why aren't they moving? What are the biggest challenges? And we're writing all this down on a whiteboard or okay.
yes.
Keep rolling.
So when you had asked, like, what are the key components in healthcare? I think it's one, respecting that you don't have long periods of time to do a day-long design workshop usually. But what we'll do is break them down. And the way we break them down into pillars is that first is sort of using the Einstein quote, where if I had an hour to solve a problem, I'd spend 55 minutes understanding the challenge and 5 minutes working on a solution. We tell people that right at the beginning. We want to really understand the problem. Even that in healthcare is often viewed very favorably by our frontline staff and providers, because they're like, oh, somebody's really asking us and trying to understand the problem. And these are people that have great insights into problems, maybe have worked in that office for 20, 30 years. And so we do design research and then get to the creative part of prototyping. And we call that a diamond approach or double diamond approach, where we diverge, have a lot of ideas, and then converge on something we're going to try. And then we do supported implementation, because change in healthcare is hard. And then one of our key pillars, the fourth pillar that is so important and often not thought about in innovation up front, is our impact pillar. So we have a pillar with which is led by a wonderful woman, Dr. Bonnie Blanchfield, who's has a doctorate in healthcare management, and she just goes to projects that we're starting and says, when people are starting to think about what the solution, she goes, okay, what will success look like when we're done? And practically, how are we going to measure that to show that we're either successful or not? Because we're gonna iterate or not pursue ideas that are not working.
Okay, let me unpack some of this, because I want to stay really organized for everyone listening. So, stupidest ideas first, question storming second, Then we get into solution finding. This is an hour-long meeting. I'm assuming 5-10 minutes where you're setting the stage. So now I've got 50 minutes left. Stupidest ideas may take 5 or 10. Okay, I'm just doing the math here. Now I've got 40 minutes left. Question storming takes 30, 25. Now I've got 5-10 minutes left. And that's where you give, like, because you've already given the Einstein pep talk, 55 minutes to understand the problem, 5 minutes to solution. And then we grab some quick solutions, and then does the supported implementation happen afterwards?
Yeah, and even just to highlight some of the design research for my small team made up of designers, an entrepreneur in residence, an impact person, and designers of different ilks, graphic design, industrial design. We've done a lot of background research trying to observe what's going on in the hospital and people moving so that we can use those as prompts, asking individuals like, hey, how often are you moving? And so a lot of that design research is happening between and then presented, right? So one of the things with design research, like we're learning some more during the question storming where people are really validating a lot of the design research or they're bringing up new points. But our small team made up of design researchers, industrial designers, graphic designers, as well as policy people. We have an entrepreneur in residence. They're fantastic. They're doing a lot of design research where we're really sorting out what's the evidence, what are observations that we've done in the hospital, maybe coming up with hypotheses why people aren't moving, as well as asking people. And so that's some of the pre-work that's done. And then it's during the sessions where we really utilize people's insights and inputs. And then one of the best parts to get to is beyond the design research. One of the most enjoyable things that we're not often encouraged to do or given the space to do is be creative. And that's where we talk about the double diamond, or the diamond where you diverge in ideas and then you make assumptions and use some hunches, and there's ways that we converge into an idea that really seems sticky. And then we'll go back and work on that as a team in our design studio and come back and present some different options.
So just real quick, so we come out of that hour meeting, you come out of it with a much better understanding of the problem, but and maybe some ingredients for a solution. But now you go back to the lab and put that into the lab and come back with a solution, almost like a consulting company does.
Yeah, we might. It depends on the problem. But with the mobility speedometer, we set up in advance that we were going to have 3 of these lunches. We're going to buy people lunches. They're going to come on 3 different occasions. If somebody went to the first one and was unable to come to the second one, we'd have them nominate a colleague that they thought would be great. What we often found is people would say, it's so much fun. Can I bring a friend? And I'm going to come, even though I didn't think I was able to. And then because they feel engaged in the process, people like to scratch their own itch, right? It's a problem they've been faced with. And so we did these as 3 sessions. And one of the things that they really came out with, which was an aha moment, is after this divergent period where they thought about solutions that were sometimes high tech, maybe even expensive, where they were talking about positional sensors or pedometers on every patient and some way to monitor those.
When you say they, who are you referring to? Your team or?
Oh, These are those nurses, PCAs, advanced practice practice providers, and the hospitalists who are saying, "Hey, could we do this?" One of the solutions that we converged on ended up being the most elegant solution. Is like, "Hey, if we just got patients, families, and providers to know what somebody's mobility status was when they walked in the room and understood it, and then within each of those boundaries knew that there's a set of activities they can choose from to move that day, we would be in a much better position." So we took that basis of a solution, came up with lots of different other possibilities, and then presented a few on our next visit with all these providers, and they settled on choosing what we now call the mobility speedometer, which was a red, orange, yellow, and green mobility status of the patient with recommendations of how they move in each level. And then there were handouts given at the 6th grade reading level for every patient and their family to sort of look through. And what we found upon implementation was incredible. I don't know, I can talk about that in a little bit.
Yeah, so the result of this exercise is a mobility speedometer that basically labeled each patient as red, yellow, or green in so much as their ability to move from a safety risk standpoint.
Yes.
And okay, great. This is great. I want to get in. I want to take the next step here, as you just teased out. But before we do that, I want to just cycle back. You mentioned at some point 4 pillars. I don't think if we clearly identified all 4. So I just want the listener to hear all 4 of your pillars.
Sure.
Yeah.
Yeah. So the 4 pillars are really that design research where we're understanding the problem and spending 55 minutes of an hour understanding a problem, and then 5 minutes working on a solution. That is both actual and metaphorical, but because it might take a long period of time. So that design research is essential, understanding the problem. The next pillar is prototyping, where I think it's key to not hold on to your first concept of a solution too tightly, but be able to and willing to relinquish components of it or the whole thing, so that it becomes better with feedback. And then once we get to what we always call an interim solution, then we move to our next pillar, which is supported implementation. We make a plan with the hospital wards that are developing this, or the clinic, or the providers, and make a plan for how they're going to implement, try it, measure it, and we had several people observing on the ward. So that's supported implementation, just with this recognition that any change in a constrained system such as healthcare is hard. But to move to a new status quo or a new way of doing things takes some support. So we'll do that. And then our 4th pillar is the impact pillar, where we're measuring the impact of everything that we do.
Got it. Perfect. So let's now take the next step. So we've done a lot of the research. We've got a mobility speedometer. What are the results?
Yeah, I'll tell you. So again, part of the speedometer and the form factor and everything was just so beautifully designed by our industrial and graphic designers. Just fantastic. But then there was feedback given, and they would edit it based on what the size is and what was understandable to them. And when this got implemented with the handout and that implementation and measuring by the nurses and other providers, what we found is that people were moving 300% more. The actual decline, everyone declines when they get sequestered in a bed in the hospital and they're sick. But the decline in mobility went from 41% to 19%. And remarkably, from a health system standpoint, was that it dropped length of stay. It was 0.17 days that people would stay in the hospital less for medicine patients, and 0.25 days in surgical patients. And that was remarkable for a very low cost intervention that didn't require hiring more people.
That's going to get the CFO's attention. So 300% increase in mobility is what I heard, that first number.
Yes.
Define that again. So that's not increase from where they were, because there's a decline in mobility, but an increase versus the benchmark.
Yeah, versus the before and after. So we studied these same wards for 3 months before implementing the speedometer and looked at the number of documented mobility episodes. And
And that translated to a reduction in decline from 41%, which is almost half, to only 19%, which is great. And that translated into an LOS reduction, which is when the dollars start ringing in. Great.
Yeah.
Awesome. Can we jump? Are we good, or is there something that you missed out before? I want to jump to prototyping as a strategy in a moment, but before we, which is pillar 2, right? But let's. Is there anything about this Salem Hospital story and the speedometer that we want to put a bow on, or we got?
Well, I think it's one of the things that when you recognize this dual benefit, that the people that are involved in the process of creating a solution are fantastic advocates and early adopters of that solution. And now the speedometer is scaling throughout MGB as we speak. It's in over 900 beds.
So we went from 70 in a pilot, and now we're in over 900 beds. And for people not in the area, how many hospitals?
There's 9 hospitals within the MGB system.
Exactly.
2 large teaching hospitals, Massachusetts General Hospital and Brigham and Women's Hospital.
Never heard of them. So how do you? Let's get into prototyping in pillar 2. Because prototyping is tricky, right? You've got bureaucracy, you've got a big CYA culture. Right? There's a lot of risk, patients' lives are at stake. How do you create a very effective way to test something, refine it? Because testing, it's not going to be perfect, meaning it's not going to be optimal. I dare say almost underperforms or fails. Refine it, and then once you get there, then scale and go from 70 beds to 900 beds.
Right. So maybe I could use a different example for prototyping.
Sure.
So during the COVID pandemic, we were asked by the CEO of the hospital, who had seen a video from South Korea that was of a testing booth where the patient went into essentially a phone booth.
Which not Salem Hospital, right? Different hospital.
Did I say Salem? I'm sorry.
You just said hospital, like a blind.
It was a hospital in South Korea. So
the CEO of the hospital.
Oh, the CEO of Mass General Brigham's health system.
Okay, got it.
Yeah. She came to the Springboard Studio, or had somebody come to the Springboard Studio, who essentially she had been asking, like, who might be able to build one of these. And when I was asked, it was during the height of the pandemic, where it was ramping up, and perhaps naively, I said, yeah, we'll do that. And what that involved was, within 9 days, there were a number of providers around manufacturers around the Boston area who weren't working. And so we were able to get that booth made within 9 days, and it was in place in Newton Wellesley Hospital's parking lot. And what we were doing with that prototyping is not putting any patients in it initially. We were looking for form factor, but we had it in place, and it was the nurses who were testing already, wearing their gowns, moving people through, driving up, one at a time, who got in the booth. And they quickly, one of the insights from a nurse, Amy Israelian, was she said, hey, why aren't I inside the booth rather than the patient? She said, why?
Chris, for context, the purpose of the phone booth in the South Korean hospital that came up with this was what?
Yeah. So the idea of that phone booth, remember, is because there was a strong suspicion that was confirmed that COVID is aerosolized, that if we kept a patient contained while they were putting a swab into their nose and making them sneeze, that having a plexiglass booth with rubber arms into it would protect the health worker and prevent the spread of COVID. And so what we did is actually sat there and studied the video that they had released. It was on YouTube, and we actually called the head of that hospital, who was really involved with making that booth, and and then when we developed a bit of a relationship with him, we're calling about how he was communicating through the, and they had a phone system. We ended up, he goes, but there's things we would do differently, which we took. And then when we called him back and said, hey, we got all this feedback from nurses, we're going to change it in this way. He was like, that sounds fantastic. And it was this great exchange. And I have to say, we really went back to the people in administration who asked us to build this. And we said that with respect to the impact pillar, said, what would success look like? And they said, well, we're not testing enough people. So if we could increase our throughput, if we could keep our staff and patients safe, that would be success. And they said on top of it, we're running out of gowns. At that time, we had PPE was in critical supply. And they said, if we could drop our PPE usage, that would be fantastic. And so we had that as a single, as goals in mind to solve that problem.
Right. So now you put it up in the parking lot, and now we have this idea coming out of Amy, who's a nurse there, that, hey, I should be in there.
Yes. And so and we're partnering with a number of people, right? Manufacturers, healthcare innovation partners. We're working around disciplinary lines, and we have infection control in there, sort of evaluating. And what we did is literally go back that next day after all this feedback, unscrew the walls of that booth, turn them inside out. We cut some more armholes and had the booth with a HEPA filter on the top of it, so that person inside was safe. And then what happened is, after evaluation for safety and the HEPA filtration and the gloves, etc., we set up what we called sneeze guards on each wall. We called the booth a hexapod because it had 6 arms, and one of the walls was where the tester would go in, and quickly we saw that end user was saying, "This is my happy place," and so the testers were sort of saying, that's where I want to spend my day. I want to be the one inside. And then what would happen is somebody would come up to one side of the booth, be tested, walk away, and then people who could wear the same gowns would go up and wash that wall while a patient went to another wall. And so that solution, the final solution that was approved by infection control and in place, started to be used in 28 days of that initial call for us to build that booth. And that was going through iterative cycles of the prototype and doing the sort of safety evaluation at the same time.
And so, and I guess this is a question not just related to this Newton Wellesley Hospital example, but for any program, when you're thinking about Pillar 4 and measuring impact, how do you know when the design intervention is truly working, both clinically or operationally? Like, how do we know we have success? Is it cool because it's just...
Yeah. And just as the last thing on prototyping, people think of a physical thing often, but just to highlight that even care redesign can be prototyped and drawn out as a journey map or flow diagram. So to lower the barrier of people thinking like, oh, we don't have manufacturing abilities, they can prototype many solutions in healthcare, even without that. But the way you measure impact is you have somebody saying, what will success look like? And so that was those questions about throughput, gown usage, safety. And I'll tell you, when we measured it, so we got all the data that was really being measured before implementing these in the testing facilities and compared it to after implementation. And testing capacity increased 354%. Gown usage dropped 97% from the use of these. None of the users who were using the or testing in these devices, we were monitoring. None of them had been getting sick with COVID. I'm sure some of them got COVID over time, but not from those booths. And each one of those booths, when we did the economic calculation, was saving the hospital system. In the end, there were 6 in use throughout MGB for almost 2 years, and each of those booths saved the system $1 million per year. And so it was a system that increased throughput and dropped costs. And I think that is one of my encouraging things to your listeners that are just seeking better ways to solve problems in constrained health systems, is to look for those examples where they can address a focused problem, measure it, and show the success of doing this by starting a little bit slower, by understanding the problem, but coming up with a solution that's more compelling to the end user and likely to be implemented.
And compelling solution is a qualitative or subjective term, but how would you guys define it?
Yeah. We think of not just those end markers, like saving $1 million a year or dropping gown usage 97%. There's qualitative and quantitative, but there's the thing where I really was saying, when we got the feedback from nurses that were saying, like, what don't you like about being in the booth? What is uncomfortable to you? What is, where, and we consistently heard that feedback of, that is my happy place. I like to be in the booth when I'm going to work and know that it's my day to be in the booth, or my half day to be in the booth. I bring a little, speaker and I play music and I like being there. And that really is important to us. The other thing that we find compelling for the end users is providers want better care for their patients. And when you can show them, back to the speedometer example, that their patients are moving 300% more, that they're leaving the hospital, they're declining less, they were compelled, more likely to implement that solution and say, oh, this is important, it's better for my patients. And then the third thing that's compelling is not only if it's comfortable and we like being in the booth, but anytime that we're designing, we're not just thinking, oh, here's another thing for that primary care doctor to do, here's another thing for that nurse to do on a daily basis. We think about, what can we remove from their workflow that actually makes their lives better? And so we really think of our end users as being the patients who are benefiting, or we like to say people, not patients, and then the providers.
Great. So let's actually, now that I think we've got everything, all the ingredients on the table for folks to think about their own approach to innovation, how to address problems, how to measure it, making sure that's a compelling solution for all the stakeholders to use and benefit from. So let's take our 4 pillars: understanding the problem, the design research, the prototyping of the pilot, the support and implementation, and the impact. And let's take that to a global setting, because I know your work's not limited to just New England here. Let's go to a global setting and tell me about a time where you were able to apply these principles of human-centered design, regardless of resources or technologies, and how that worked.
Yeah, I'll tell you, this is something that is very different than many people had initially assumed when we started working in low resource settings in 2011. We were working mostly in India and Uganda, and recognizing that the truly the resilience, grit, and ingenuity of frontline providers, many of whom I'd worked with for years before, either in Southeast Asia or in Africa, was really compelling to me. And it was before I had the language around design thinking, but that's exactly what we were doing, is starting with this problem, trying to bring patients and providers together to identify what's actually the problem, and then getting the right talent pool around them right early on in a process. And I'll give you one example that really strikes close to home. I spent a year on the Thai-Burmese border with my wife as a MGH refugee fellow, a Durant refugee fellow in 2003. And since that time, I've started training with midwives or birth attendants on newborn resuscitation. And I really was focused on training more people. And I think that's been a global phenomenon. There's about 1.8 million babies who are born per year that are not breathing at birth. And the vast majority of those can be saved just by getting air into their lungs and breathing for them. It doesn't even have to be oxygen. So I'm working with a pediatrician who's a brilliant pediatrician in Uganda named Dr. Dada Santorino. And he, going through, he had this mindset of being able to say anything. He said, well, I go follow up the people that we've trained. And he said, in 2 months, I'm watching them and they can't get air into the lungs often. And is there some way that we could develop a technology that could show me what's happening so I could instruct them? And it was this light bulb that went off in my head. I went, whoa, we're focused so much on just getting more numbers of people trained, but we're not thinking about the decay in their skills or whether they're actually being successful. And then we did the design research. So we started looking, well, why are these people not getting air into the lungs? And it was from observations and papers. And there's some papers from the US that shows 20% of people trained in neonatal resuscitation program can't get air into the lungs of a mannequin as they leave training. And then there's another 35% drop off within 3 months. And so we were like, that's interesting. And the solution, even from what Dr. Santorino was saying, became very different as we delved into the problem. And so we like to say, as fantastic entrepreneur in residence, we have Mr. Jim Miller. He said, look, healthcare is hard. It's hard to move the oak tree. Let's break it down into its component toothpicks. And when we broke it down, the issues from not getting air into those lungs, when you squeeze that bag that you see and you put a mask onto the mouth, or nose and mouth of a baby, we broke it down and it became that the issues were people were breathing at the incorrect rate. They would get the baby's head out of position so that there would be a blockage in the airways. They couldn't get the mask fitting on right, so it would leak. And then sometimes none of those things happened and people would breathe too harshly. And so what we did is change, and it was different than what was imagined. When people first came together, like, oh, maybe we should make a machine that gives the air and it prevents all these variables. And what it was a lot of understanding what was the problem in that delivery. Let's just give feedback, not to Dr. Santorino as the instructor, but actually to the user in real time, either in training or in actual use. And so we developed the augmented infant resuscitator with an engineer from MIT who is a fluid dynamics engineer, and made a low-cost add-on device to their existing equipment that in real time showed the user with symbols whether they had a leak, a block, they were breathing at their too fast of a rate or too slow, or if they were breathing too harshly, so that to remind them to do a slow, gentle breath. And when that device was trialed, both in Uganda and in India, it showed that people achieved proper ventilation in less than half the time and maintained it twice as long. And that was remarkable to us. And subsequently, it's been trialed in India and Kenya, and is shown that actually, as a training device, just sitting it in a birthing center where people would practice a couple times a week, their skills for the first time, what we've seen is rather than their skills declining less precipitously, their actual ventilation skills are improving. So in full disclosure, I'm involved in that solution in the augmented infant resuscitator, but it's just so compelling to me about how it came to be a very elegant solution that fits into bag valve mask and is very intuitive for the end user. So when one of the criteria for that, which we got a lot from birth attendants in Uganda, was the symbols and understanding the symbols very simply. And when we trialed it, one of the criteria was the training for how to use it had to be under 2 minutes. And what we found is usually, even in the trial, we would train people, and after 1 minute of telling them the things, they go, no, I got it. And they would use the device.
I mean, this template you've created, this approach, I mean, it's so transferable. If it could work in India, Uganda, it can work in any market here in the U.S. and finding innovative solutions. It's just brilliant. I know we're going way over time, so I don't want to keep you longer than we already have, but I want to end with one or two real quick questions. First, like as you're thinking about as a leader running an innovation lab in one of the most well-known hospital systems in the world, can you think, and it could be outside of MGB, Chris, like what's a bright spot, a practice, an idea, or an experience that you've either read about, watched presented, learned about, that's outsized the impact on how you lead and solve problems and run innovation at MGH or MGB, excuse me?
Yeah, I think that one of the things that has really influenced my career has been seeing, as I mentioned before, the grit, resilience, and ingenuity of people who are under strain. So when I go back to that 2003 experience in bamboo hospitals on stilts, seeing the ingenuity that came out of people who are viewed as they're labeled as refugees, or they're people receiving care, but under the strain they were in, the ingenuity that they would have in terms of disease control and prevention, of treating with minimal set of resources, has influenced my entire career. And it almost gets back to your example of that, looking for positive deviance with infection control, of a janitor that figures out, hey, if I wash this room with a checklist so that I don't miss anything, I'm going to do better. And that drives me. And I think that the two things that really someone wanting to implement design thinking in their health system, it is a multi-use rocket. You can point it at challenges that you face, big and small, engage people so they have a sense of agency in their own solutions. They're early adopters. They will champion the solution and make it more compatible to their colleagues. But you're going to be able to set the parameters of what are those goals? What does impact look like? And solve challenges with the best resource that you have in your health system, which is your human resources.
I love it. Just so you know, I mean, I don't know if I shared this with you, but what inspired me to start the show back in 2014 was reading about how a group out of Tufts goes to help solve the crisis of malnutrition in kids in the country of Vietnam in 1990. And rather than look at a big, expensive, complex solution, they went and found the poorest families, right? The ones who are under the most stress with the least resources, who had the healthiest kids. And once they saw how those families were nourishing their kids differently from everyone else, they figured a way to scale it. And in 2 years, malnutrition dropped in the country by 20%, 2.5 million kids went through the program. And that's where, the authors were like, what these guys did, just one person in particular, the late Jerry Sternan, he found a bright spot and he figured out how to clone it. And that's what inspired the entire show. So yeah, I mean, that's exactly probably what's inspired you. We're like sort of on the same wavelength there.
Yeah.
I really like, where can people follow and find your work?
Yeah, I'll say you can follow it at www.mgbspringboardstudio.org. You'll see some case examples, some mechanisms of working. I'll also say, if you want to look at that ventilation solution, it's at ebinnovations.net. and certainly you can see ways to reach out to us on our website. But I want to highlight that there's not a high barrier. Everyone is innovating every day, but figuring out a way or a process to move forward practically towards better solutions is within reach and is a better use of the meetings that we do have in the hospital.
Love it. What I'll try to do, first of all these links will go into the show description. We'll also try to maybe summarize some of the key points made today in the pillars in the show description as well. Of course, folks can grab the transcript of this episode as well if they really want to dive into all the key things you said after they listen to the episode. Really appreciate all the time you took just today and even just preparing with me. This was awesome. I could talk to you for hours. Everyone listening, we don't spend the time you spend with us for granted. We know you're super busy, and hopefully you were able to garner some really good insights from today's conversation with Dr. Kristian Olson. Remember, one bright spot on one floor in one hospital changed the trajectory of care nationwide. Same can be true for your organization. Use the strategies, the examples, the framework you heard today from Dr. Chris Olson as your seeds. Scale what's already working. You could create your own moonshot story. That's our mission, to inspire your thinking and support your work to improve healthcare for all of us. We produce this show for you. Remember, this is your Bright Spots in Healthcare podcast. Thank you, everyone.